we know, as a physician, Indian physicians, we learned a lot in medical school. We are smart people. But how do we apply our knowledge in daily clinical situations? I'm going to go over there. You know that most important of the organ of the body is what? Talk to the girl, they will say it is heart. Talk to nephrology, they will say the kidney. Talk to anybody else, pulmonary will say it is lung. But basically it is your brain which is the most important organ of the body is. And what brain really needs is only two things. What are those two things? One is glucose and second one is your oxygen. Right? On an average, everybody got enough glucose in their bodies to give glucose supply to the brain and to the rest of the body. But the oxygenation is a very dynamic process. How to get oxygen in your body, in your brain, is just only by one mechanism. What is that is? You got to breathe in oxygen and breathe out oxygen. Normally, room air oxygen concentration is about 21%. When we breathe in, we are breathing in 21%. When we breathe out, it is about 16%. That means we have extracted 5% of oxygen from the room air. Let's see how does it really affect us. We take the oxygen in, goes to the lungs, goes to the heart, and by the CVS system gets distributed to the whole body. Now, imagine if your brain does not get an oxygen. We all know that brain can tolerate anoxemia for how many minutes, how many seconds? Any idea? Take a pick, take any number, doesn't matter. In other words, try to hold your own breath. Let's see how long your brain is going to be active. Right? For example, just try to hold your breath. Let me see how much you can hold your breath. On the count of 3, I'll say, hold your breath, please. 1, 2, 3. Hold it, please. I'm going to keep counting. Who breaks out first? People still breathing? No, they are not breathing. They are holding the breath, right? See, somebody broke. 20 seconds, 30 seconds. You still going? All right. So on an average, a human being can hold their breath maybe for about 30 or 40 seconds, not minutes, not hours, 40 seconds. If you are regularly yoga guy, you can hold your breath for a little longer time. But how long? Maybe maximum 2 or 3 minutes. What happens after that? You start breaking your breath. Why? Brain start telling your body, hey guy, if you don't breathe for me, I'm going to die. Okay? Then people start breathing again after 2-3 minutes. Some people who are kind of divers, they can hold their breath in the water maybe for 3-4 minutes or 5 minutes. But no brain can tolerate an oxemia for more than 5 minutes. Right? If you can understand that, that means you understood the pathophysiology of the head injury. Now, let's apply that knowledge to our lecture here. These are just a number. That was about 5 years ago. Okay, why we have that? We are seeing every day traffic like this. Okay, everybody sharing the road. Okay, whether you're pedestrian or bicyclist or motorcyclist. All right. So what that means? We are prone to get head injuries. Every day you see so many accidents. Okay, what is the most important thing in the life? Is the life. If you get involved in the accident, you get hit, you get general body trauma, your brain is also affected, and you can imagine what happens to you. So the exactly same thing is happening here now. Can you play the video, please? The video, this was recorded in Andhra Pradesh. How do people get the head injuries? Okay. You don't have to listen to this. Can you see the audio now?
నిర్లక్ష్యంగా వాహనం నడపడం, రాంగ్ రూట్ లో రావడం, వీలు కాకుండా ముందుకు వెళ్ళడానికి ప్రయత్నించడం, సిగ్నల్ పడ్డా వెళ్ళడం, టర్నింగ్ లో నిర్లక్ష్యం, రోడ్డు దాటే సమయంలో సరిగ్గా చూసుకోకపోవడం, ఇలా అనేక కారణాల వల్ల నిత్యం రోడ్డు ప్రమాదాలు జరుగుతుంటాయి. నిబంధనలు పాటించకపోవడం వల్లే ఎక్కువ ప్రమాదాలు జరుగుతున్నాయని పోలీసులు చెబుతున్నారు. ప్రమాదాల విషయంలో ప్రజల్లో అవగాహన అవసరమని పోలీసులు చెబుతున్నారు.
We can stop that. So you can imagine how the life is cheap here. What we can do a better job than that, right? We can definitely prevent the roadways traffic accidents, the biggest mortality causer in India, roadways traffic accidents. People who are in late 70s, 80s and 90s, we can understand that. They are dying because of natural causes. But these are the unnatural causes. People are dying on the street. And these are the healthy bodies. We deserve better than that. We have to avoid this. We have to make sure India is a safer country. And what we can do, we must do for India. Let's start with the case scenario. I have a 15-year-old guy who was working on the roof and he falls off the roof. Okay? And now, when we examine the patient, his initial Glasgow score is 12. You know Glasgow score is eye-opening, verbal as well as the motor. His GCS score is 12. Normally it should be 15. Okay? 14 and 15 is classified like a mild head injury. Moderate is about 8 to 12. Less than 8 is your severe head trauma. And after admission, his GCS goes down to the 6th. This is the biggest drop is. Now, what happens in the head injury? One thing you guys have to understand that what is that is, once your brain gets injured, you sustain a primary head injury. Primary head injury is not reversible. Whatever damage happened to the brain will stay there. Nothing you can do. But as a physician, what we can do, we can prevent secondary brain injury. That means we want to make sure if he's come across the patient who's a head injured, we want to make sure that brain gets enough oxygen. You know that when you're kind of out, when you sleep, your reflexes are down, breathing is down. Okay? But when brain is injured, okay, you become unconscious, lateral flat on the back, your oropharyngeal secretion keeps on going. When you become unconscious, your tongue falls backward. That obstructs your airway. That means you cannot breathe in. Ultimately, what is happening? That brain is not getting any oxygen. That is the biggest killer of head injury. That means if a guy who sees a head injury patient out in the street and who's not breathing, his job is to make sure patients start breathing. How we can do it? It's a simple maneuver. If you have head injury, chances are you might have some C-spine injuries too. That means what? You don't need to do head tilt and chin lift maneuver to breathe for the patient. All you have to do jaw thrust. Open up the jaw, and that is good enough to open up the airway, let the patient start breathing. That means what? Who the best treatment giver out on the street? It's not me, it's not you, it's the bystander who's sitting there, who's watching the scene, who's watching the accident. All we have to do as a physicians, we are smart people, want to make sure each and every citizen of India knows how to do CPR. If we can convey the message across the board, we did our job. Now, a brain who's sitting out on the street for half an hour, 1 hour, who's not breathing. You may transport the patient to the trauma center. You may transport the patient straight to those surgical OR. Nothing we can do because brain only sustained severe hypoxemia and oxemia. Right? So I'm going to stop there because I was given only 10 minutes. My message is we need to get everybody involved in the teaching people how to do bystander CPR, how to manage the airway of the patient. That is the most important thing is. If you can train all our police walas, if we can train all the school walas, if we can train anybody who wants to learn something, we must teach him science of the life and how to start resuscitation on those patients. If we can do that, we can minimize the mortality to probably more than 95%. What happened to that Maharaja Gajari's son? He fell off the horse. He couldn't even breathe. He was anoxemic for a prolonged period of time. Then let him have a vegetative body. Okay? We can do better job than that. All right? I'm open for any questions if you guys have any questions for me. All right? My 10 minutes are over. All right? Huh?
If you want, sir, you can proceed.
No, that's okay. That's up to you guys. If I can maintain the airway. Plus, that is the only sure way of giving oxygen to the brain. Right? Now, certain myths about the hyperventilation. In head injury patients, you want to make sure PCOT is maintained between 30 to 35. Okay? People become sometimes very jealous in hyperventilating the patient. No doubt, it does reduce some kind of cerebral edema because of the cerebral vasoconstriction. But at the same time, that makes the patient very hypoxemic too. You do not want to do it. So you want to maintain PCT around 30 to 35. A brief period of hyperventilation is okay to cut down up to 25, only for a brief period of time, nothing more than that. Same thing which I'm going to do here right now is little brief period of hyperventilation. Now this one, we did intubate the patient. But certain things you need to remember in head injury. You know our adult brain. You know what is the weight of your brain is? It's about 1.2, 1.3, something like that. Liter or kilo, whatever. And the brain is enclosed in a closed shell. That means brain has no way to go anywhere. That is the reason you get early signs of cerebral edema. If you have same kind of injury on the leg or the thigh or arm, it has a space to expand. Our brain does not have much choice. Okay, 80% your brain material, 10% is your blood vessels, 10% is your CSF. It can play somewhere between 10 to 20%, not more than that. You know that once if you are head injured, you have some kind of protective reflex, what is called it? Cushing's response, right? That means if you are head injured, your blood pressure shoots up. Why? It's the body's defense mechanism. Remember, do not cut that blood pressure. You lower down the blood pressure, you're going to cause cerebral hypoxemia and ischemia, and that is not good for the brain. Okay, so you do want to maintain that kind of hypertension. Right? Normal ICP is 10, more than 20 is abnormal, more than 40 is definitely severe ICP. Right. Now, this is a very vital slide here. Mean arterial pressure minus ICP intracranial pressure equal to cerebral perfusion pressure. Normally, MAP is 90. MAP mean arterial pressure is what? Systolic plus twice diastolic divided by 3. That makes your MAP. Okay. ICP is normally 10. Now, you maintaining cerebral perfusion pressure of 80. Now, if your blood pressure goes up, why? Because the ICP is up. At the same time, cerebral perfusion pressure is still 80, that's a good thing. Okay, sometimes what happens, we become over-jealous in the ICU, we start cutting down blood pressure, that is not good. Hypertension is a big no-no. Once you become hypertensive, you are killing the brain more. So don't do it. Okay. Few things you need to remember that what you should be doing is, hyperoxemia is not good. Only normoxemia is good. Right? So you got to maintain the cerebral perfusion pressure too. Temperature, people were talking before cerebral cooling. They used to give there's the hypothermic fluids, okay, to make sure the brain is cool. I'm not really too sure it really works or not. In the adult population, they did say in ICU settings, cerebral cooling helps recover the patient better. Okay, I'm not sure in the clinical settings. Second thing, got to avoid the hypoxemia. Third major killer is glucose. Normal blood sugar is what? 80 to 100. Hyperglycemia is deadly. Hyperglycemia is deadly. So is hypoglycemia. Hypoglycemia is not good either. So make sure blood sugar is normal too. And pH of the blood is extremely important too. Make sure that is also normal too. Besides that, everybody knows what else to do, what else not to do. Okay? You are much better than me on that token. I'm going to stop here right now. Okay. All right? I think it's better if it becomes interactive. Talk to me any question, anything. Okay? So I can really answer you. That is better to me. Right?
Are you suggesting that mannitol shouldn't be used?
It could be used briefly. You can use mannitol, you can use normal saline 3 centi.
That is what we were taught really, to start mannitol when the intracranial pressure is on the higher side. That is what we normally tend to do.
Right. Do you put the pressure monitoring system there? That's okay. They're perfectly all right to use mannitol or 3% saline, whatever you like. You can. But you cannot have.
That is why I said when you said that we should not actually dabble with the high blood pressure, but that's what somehow that was new to me.
No. The blood pressure is healthy. That's helpful to me. What is killer here is the hypotension. You want to maintain the cerebral perfusion pressure. Now, if your MAP becomes kind of 60, for example, it's bad. All right? A blood pressure of 150 over 100, 110, that's okay, that's pretty good. Why high blood pressure is bad to us?
But if you have a blood pressure of 160 something, if you have a blood pressure of 160 or something, Shouldn't they? Don't you think that mannitol should be used at that time?
I'm not sure on that token though. I do need to maintain cerebral perfusion pressure.
Cerebral perfusion can be maintained at 120, but with a
But what is the ICP then? If ICP is your 40, your systolic 160, that's perfectly normal.
okay, so that was new to me. I certainly wasn't aware.
All right. You got to maintain cerebral perfusion pressure. Anytime try to cut on cerebral perfusion pressure, that is the bad thing. Remember that. The brain is enclosed in the shell, big shell. It does not have much of the scope to expand.
Things have moved on since we were students, say about 55 years ago. But that is what we were taught at that time, that the increase in intracranial pressure should normally lead to mannitol. I mean, we shouldn't really delay mannitol. And the other piece of wisdom that we were taught is that in head injury, never sedate the patient. That is what we were taught at that time.
I'm not sure about sedation too. I mean, like appendicitis. Oh, this patient got abdominal pain. Let's not give morphine. Why? Because that is going to mask the symptoms. And we're going to miss the diagnosis.
Okay, thank you.
All right?
Regarding head injury, you are talking without me.
Yes, we were talking about you before you came. All right, go ahead.
Rajdhan sahab, this is Dr. Ramesh.
Now, I'm so happy my counterpart is here, Dr. Ramesh and Mr. Come up here, please. Take some questions for our audience. You know, very renowned neurosurgeon, our batchmate. We are really, truly proud of him. He has done so many surgeries and he has benefited so many patients in the past. Let's see what his take is on the head injury patients.
Dr. Kishan,
Yes, sir.
how is hyperoxemia harmful?
You want to talk about the hyperoxemia?
Who said this? Hyperbaric oxygen, you mean?
Yeah, hyperoxemia.
Hyperoxemia. You want to have everything normal. There's a free radical, like in RDS patients, like in ARDS patients. High oxygen no good. If you want to know detail about pathophysiology, you can read it through, but it's a big no-no. Hyperoxemia. Hyperglycemia is a deadly disease.
A pathological hyperoxemia can never occur. It can never occur. If it has got self-regulatory mechanism. So if you give lot of oxygen, it doesn't mean that body is having hyperoxemia.
Hey, those are the things that we were taught. I mean, things have moved on since then. I distinctly recall that those were the things that we were taught, and you have clarified. Thanks for clarifying that. Now, I'll be very, very careful, but I don't have to deal with head injury patients in any case, luckily. But I'll be very, very careful advising my juniors that if you get a blood pressure of 160, you shouldn't normally try to lower it by giving mannitol.
Yeah,
And
because maintaining the cerebral perfusion is very important.
the other, now I recall.
But it doesn't mean that if you increase the blood pressure, perfusion will be good.
No, it's not increasing. If you
Only
find the
thing
blood
that
pressure to be in the
don't
region of
lower it,
160,
don't allow to be low.
If you find the blood pressure to be in the region of 160, what Kishan said is that then you leave it as such, you don't try to lower it.
Yeah.
That is what he said.
That was the whole sense of showing the screen.
Okay.
Okay.
The other bit was, of course, sedation. I asked that. I just recall, I was Professor Rajdhan's intern. And Professor Rajdhan was one of those very few clinicians at that time who never refrained from prescribing sedation in head injury patients. Head injury patients normally we don't, but Professor Rajdhan always used to say, okay, you can't actually mask the injury. So that is what I remember, just that. So that is what you were saying, that refraining from sedation is probably not always advisable.
No. Let me put the thing.
Okay, go ahead.
If you want to ventilate patients properly, sometimes you have to sedate because of the asynchronous activity between the ventilator and the respiration of the patient. So sometimes you have to sedate. Number two, there is one thing which is known as you paralyze the patient by pentothal, and just paralyze the patient and give the, your whatever treatment you are giving, maybe the aggressive, maybe medical treatment, but put the patient on coma therapy. You comatose the patient. This is the ultimate in management of head injury. When you have failed, you are blunted on all sides, then you actually put the patient in the coma therapy.
Yes, the message is very much clear. So I think the discussion will go on. This time is not permitting me.
That's okay, that's fine.
Ramesh, regarding hyperoxemia, because as a orthopedic, so far as I know with intensive care, that also suppresses the carbon dioxide and stimulation of the self-respiration.
Yes, yes. I'm telling you the pathological hyperoxemia is no entity. Because this is self-regulative mechanism. But it happens in the labs that if the drive, carbon dioxide related drive of the respiration, this will be blunted. This is obvious fact.
Because while weaning the person from ventilator, you have to reduce the oxygen dependence, so that
No, that is in graded form that intensivist may really answer those questions.
Those are the important questions for COPD patients.
Especially,
Okay?
especially those cases, if there is any trauma cases with any comorbid condition like COPD, in that case, hyperoxemia is very harmful.
So then the
Because you
subject,
have
Normally,
the subject
see,
gets very much wide. You
Yeah,
see,
definitely,
so many
that's a very
things.
wide.
I don't think that we can cover up all those things.
all right. Anything else for me, sir?
Thank you, sir.
So pre-hospital care is my thingy, and this is what I believe in. This is what makes a difference in the life. I think we are done. I mean, try to invest your money in pre-hospital care. Thank you.
It is time for today, ma'am.
For me, these steps are very important. They are nostalgic feeling for me to come into this platform. In 1972-73, there used to be a television on which the match was being played in Kanpur. We used to go just see the
बीच में वो बहुत इंटरप्ट होता था, and black and white.
Oh.
Thank you, Dr. Krishna Kumar, for enlightening us. I call President Dr. Vishal and Secretary Dr. Vijay Shukla and the chairperson to please honor Sir with a shot. Sir, please come on the stage. Krishna Kumar, sir, please come on the stage. I would request Dr. Sandeep Gupta to please facilitate our chairpersons with a memento. Is Dr. Sandeep Gupta here?
Look to the audience. Look to the audience. आँख बंद.
Now I invite Dr. Ashok Singh, who will detail us about biologicals in bronchial asthma. The chairpersons are Professor Anand Kumar, HOD, Respiratory Medicine, GSVM Medical College, Kanpur. He is MBBS and MD from IMS BHU and Fellowship in Critical Care from SGPGI Lucknow. I request Dr. Sanjay Singh and Dr. Vinod Kumar to please stay back for this talk also. Chairpersons, please introduce our learned speaker.
And now I would like to call Dr. Ashok Singh, please deliver your lecture on today's topic. Biologics in bronchial asthma. Please, Dr. Ashok Singh, please proceed.
So very good morning all. I would like to thank you first the GEMSCON organizer who has given me opportunity to be part of this CME. So रात गई बात गई सुबह हो गई. We should have been in the class early in the morning, but it is very discouraging to see that such a low audience here with us. I brought a topic which is new in bronchial asthma, which is coming up from the world, and I just wanted to tell about what are the new things which are coming in the bronchial asthma. So let us talk about the problem. The bronchial asthma is a heterogeneous disease. The problem of bronchial asthma in India is almost 1.31 billion peoples of India, 6% of children and 2% of adults are having asthma. It has been estimated that approx 140 billion Indian rupees are wasted in the treatment of asthma in a year. These are all quoted from some studies. The biologicals which are approved in bronchial asthma worldwide is omalizumab, mepolizumab, racilizumab, benralizumab, dupilumab and tezepelumab. But in India we have only three, that is omalizumab, mepolizumab and benralizumab. Omalizumab is anti-IgE antibody which block the receptor on eosinophil on which it comes to act. Mepolizumab is antibody against an interleukin, that is interleukin 5, and benralizumab is the same type of molecule which is act as anti-IL5 antibody. So the question arises, should we give these biologicals to all bronchial asthma patients? The answer is no, we should not give these biologicals to all bronchial asthma patients. So to whom we should give this then? There is a clear-cut definition in which these molecules can be used. There is two distinct terms nowadays which has to be understood clearly. There are two types of words running around the world, that is difficult to treat asthma and severe asthma. Difficult to treat asthma can be managed with optimizing the treatment. But severe asthma is those which do not, we have to understand, which do not get control with high dose of inhaled corticosteroid. What is high dose of inhaled corticosteroids? Let's have a look on severe asthma definition first. Asthma which require high dose of inhaled corticosteroid and long-acting beta-2 agonist molecule or leukotrienes modifier or theophylline in most of the days of previous year, or who require oral corticosteroid for more than 50% of the times in the last year to prevent it from becoming uncontrolled. So here there are two important terms, high dose ICS, inhaled corticosteroid, and uncontrolled. What is the meaning of this? Let's have a look on that. This is high dose corticosteroid. The beclomethasone, budesonide, cyclosinide, any patient who is requiring more than this dose of inhaled corticosteroid in most of the time of the whole year, those patients are considered to be a severe asthma case. So any patient who is having requirement of inhaled corticosteroid more than this dose, there are two standard body. One is ERS and ATS, European Respiratory Society and American Thoracic Society, and GINA, a global initiative against asthma. So they said there are different high dose, their definition is different for high dose inhaled corticosteroid. GINA says that 1000 of beclomethasone will be considered high dose, whereas ERS and ATS says that 2000 is the cutoff point. So we should understand our own level. According to me, this ERS ATS is more correct. So let us now understand what is uncontrolled asthma. Those who are, this is the definition by which we can say that our bronchial asthma patient is controlled or uncontrolled. We have to see the 4-week history of the patient. These 4 symptoms, first, second, third and fourth, these 4 symptoms we have to ask. Whether the daytime asthma symptom is present more than twice in a week, whether there is any night awakening, does the patient require reliever medication in last week more than twice a week, or is there any limitation of activity? Patient is not going to work or do his job, a student is not coming to the class. So if there is limitation in the activity, that is also a symptom. So if there is no symptom in the last 4 weeks, then it is called well controlled bronchial asthma. If there is 1 or 2 symptoms, it is called partially controlled bronchial asthma. If it is more than 2, means 3 or 4 symptoms are there to the patient, it is called uncontrolled bronchial asthma. So any patient, now coming to the same slide, what is severe asthma? I have to understand, you have to understand, everyone has to understand. The severe asthma is those who require more than high dose of steroid in most of the days of previous year, or oral corticosteroid for the most of the days of the previous year, to prevent it from becoming the uncontrolled. Now what the GINA says? GINA says we should give the treatment of bronchial asthma patient, low dose inhaled corticosteroid should be started, and that can be, the dose can be increased to the stage 4 up to the medium. And if any patient is in stage 5 treatment, means high dose of steroid is required, inhaled corticosteroid is required, then it is stage 5. If your patient is on stage 5, then your patient is a severe asthma case, and it has been seen in the studies that if any patient is on the severe in a high dose of steroid and we give biological to them, their steroid dose is minimized, their frequency of exacerbation is minimized, and it is having the good benefit financially as well as working condition of the patient. This is the stage on which biologicals has been prescribed in GINA, and this I have already explained to you. Now come to understand the difference of severe asthma and difficult to treat asthma. If any patient is having these symptoms of bronchial asthma, what are that? Cough, wheeze, chest tightness. If these symptoms are there, even if giving the inhaled corticosteroids, then we have to assess whether the diagnosis is correct or not, whether the other comorbid conditions of related to bronchial asthma is controlled with the proper medication or not. So the diagnosis, in diagnosis, you have to review the diagnosis whether the patient is actually having bronchial asthma or not. So what are the diseases which mimic the bronchial asthma? That is vocal cord disease, gastroesophageal reflux diseases, anxiety, obstructive sleep apnea, COPD, bronchiectasis, heart failure. These are the diseases which may mimic like bronchial asthma. If these diseases are there, then there is a different treatment for this. If any patient is having the symptom actually of bronchial asthma, you have made the diagnosis with proper spirometry that this patient is only and only bronchial asthma. Then in these bronchial asthma patients, you have to see whether they are having presence of symptom, and then you have to check whether he is taking the medications properly or not. If he is taking the medication properly, there is adherence in inhalation. You have to check the technique of inhalation also. If there is good technique, even then his or her bronchial asthma is not controlled, then we will have to think of that this is actually the severe bronchial asthma patient. In that, we have to start the biologicals. In these patients, we can ask for a fractionated nitric oxide, which is a good marker of inflammation in the airways, and this fractionated nitric oxide may be helpful in the making the diagnosis. Once you have made that your patient is having severe bronchial asthma, then you will have to go for phenotyping of this bronchial asthma. As for the data available of all bronchial asthma patients, only 24 is having difficult to treat asthma or severe asthma. In all these difficult to treat asthma, only 17% is having actually difficult to treat asthma. If you optimize the treatment, these patients may get corrected. After optimizing the treatment, even then your patient is having problem, it means that is the severe bronchial asthma actual. And for these patients we require to check whether there is good adherence to the treatment or not, whether there is good inhalation technique or not. If these things are there and patient is having still problem, then we have to think of about the biologicals. So how to optimize the treatment, how to evaluate the difficult to treat asthma patient for biologicals. First, you see whether your patient is having problem even after giving the high dose of steroid, that are called the difficult to treat asthma. If there is uncontrolled in the bronchial asthma symptoms, then you will have to see whether there is any contributing factor. Then you will have to see there is any contributing factor for symptom not to control. If there is some contributing factor like presence of allergen, obesity, sleep apnea, anxiety. If these contributing factors are there, then you should try to optimize those factors, treat those factors. And if after that also your patient is having problem, then you have to see you have to give the treatment of high dose steroid for longer duration of time. If high dose inhaled corticosteroid are given for 3 to 6 months and your patient is having problem still, then you should think of giving the biologicals, and these biologicals are to be given according to the phenotypes. So there are two major phenotypes. In this I have given so many: aspirin sensitive bronchial asthma, allergic bronchopulmonary mycosis, severe or late onset hypereosinophilic asthma, allergic asthma, non-eosinophilic asthma. In this there are so many. So majorly if we see, there are two main types: allergic predominant asthma and eosinophilic asthma. In allergic predominance there is high IgE level, high FeNO also, but in case of eosinophilic asthma this FeNO will be very high, IgE will not be that high. So in this way we can do the phenotyping of these patients, and after phenotyping we can give biologicals. For different phenotype there is a different biologicals. If total Ig is more than this, total Ig, blood eosinophil count, sputum eosinophil count, FeNO, these are the markers of severe asthma. In one study it has been seen that FeNO and eosinophil count is directly proportional to rate of exacerbation. If FeNO is high, eosinophil count is high, the exacerbations will be more to the patient. In such patients we have to think of about the biologicals. This is the mechanism by which you can understand where these molecules are working. Mepolizumab used here, IL-5. Benralizumab is work on the receptor of interleukin-5 on eosinophil counts. Whatever the allergens or pollution causes damage to the epitheliums, they releases various cytokines, and these cytokines activates the Th2 cells. These Th2 cells gives many interleukins, and they activate the B cells, and IgE is produced. Here the omalizumab comes to work and give benefit to the patient. This is the mechanism of action of mepolizumab and benralizumab. You can see benralizumab actively kills the eosinophils, whereas mepolizumab is passive eosinophilic apoptosis. It is been caused by mepolizumab. Now I am coming to see what are the side effects of taking the oral corticosteroid. We all know that it may cause various problems. So to avoid the corticosteroid, we have to use the biologicals. The dose of biologicals in India, there are 3 biologicals: omalizumab, mepolizumab and benralizumab. Omalizumab has to be given in dose of 75 to 375 depending on weight and IgE level of the patient. The frequency of giving this is 2 to 4 weeks. Every 2 to 4 weeks, mepolizumab has to be given every 4 weeks, and benralizumab for the first 3 months we have to give every 4 weeks, and after 3 months we have to give every 8 weeks. This is the dosing of omalizumab. If there is weight band of 30 to 60, 60 to 70, IgE level 30 to 100, like this. If according to weight and IgE level we can give omalizumab every 4 weeks or every 2 weeks. This is the dosing. benralizumab, as I already told you, the first 3 months we have to give every 4 weeks, and after 3 months we can give every 8 weeks, means every 2 months we have to give one injection of benralizumab. These are the molecules I already told you, and in various studies it has been seen that they are very safe in use and they are efficacious. The adverse effects are very minimal in these biologicals. So the question arises, is there any overlap of the symptom, overlap of the phenotypes? Yes, some of the patients who are eligible for omalizumab are also eligible for mepolizumab. It means they have both IgE level raised and eosinophil count raised. In one study it has been seen that those who are eligible for omalizumab are eligible for mepolizumab also, and those who are eligible for mepolizumab are eligible for omalizumab also. In few cases this can be seen. This is the all mechanism of action and effect of these biologicals, and this is the new molecules which are now about to be coming up, that is TSLV, anti-TSLV, that is tezepelumab, which is thymic stromal lymphopoietin antibodies. This is new molecule which is about to come. That's all. Thank you.
Thank you, sir, for such a nice and informative lecture. I would like to ask one question.
Yeah, sure.
In certain cases, when there is a bronchial asthma and COPD overlap syndrome,
Yeah.
what is the role of biological in such cases?
Actually, I already told in my lecture that if there is doubt about the diagnosis, if there is overlap, you are yourself understanding that the patient is having overlap of COPD. So it is better to correct the COPD first. If after COPD treatment your patient is not controlled with, then we can think of about asthma, and then biologicals can be used to manage their asthma part separately.
Okay, so what is separately managed?
Yeah. Even after giving the COPD treatment, your patient is not having good control of symptom, then we can think of about other part of the
What is
asthma.
your experience about the biological?
Experience about biologicals, I will say omalizumab is very good. If any patient is having more than 500 total IgE level, it is being seen that it is very much good in controlling the exacerbations.
After few course of time, can we stop the steroid?
Yeah. After?
Few course of time when we have started the biological?
Yeah, we can stop it after 1 year if your patient is having good control of symptoms.
How long we can use this biological?
1 year to 2 years maximum.
Maximum.
Yeah.
What after that?
After that, you have to keep the patient in follow-up. If your patient is having good control, I have the patient in which I have used the biologicals, omalizumab especially, and the patient has not came back that I am again exacerbating my symptoms regularly.
Is there any side effect of these biologicals?
Side effect of omalizumab as such is not very high. Only thing is anaphylaxis. So the first 2 or 3 doses you have to give by in observation, and after that patient can take at home also.
Okay, thank you, Dr. Is there any other question?
From the audience side? Okay.
Okay, thank you.
Okay, fine.
Thank you.
Dr. Vinod was willing to know the cost of biological.
Yes. This is very important and very genuine question. The cost of biological is very high. Omalizumab is coming in about 20 to 25,000 one dose. Yeah. And mepolizumab is much more costly. Benralizumab is more than that, but the dosing is less, so overall cost of mepoli and benralizumab is almost equal. and it comes in lakhs. Mepolizumab and benralizumab is coming in price of more than lakhs, but less than 2 lakhs. Yes, Dr. Avadhis.
The problem with using biologicals in this part of in our society, that is in Northern India, is that cost is very high, and you have to be very choosy in prescribing any of the biologicals, because there are, as you have shown, there are only 3.7% patients who are truly require biologics.
Very right.
So it's selection of patient and cost of therapy are two major hurdles in success of biologics as well.
So it is in India it is less in use, but in foreign countries where there is price is not a matter, there they are using at, and the advantage they are taking is their frequent exacerbation of bronchial asthma is minimized. Okay.
Thank you, Dr. Ashok Singh, for elaborating on the subject. I hope it will benefit all. Chairpersons, please honor our speaker. Chairpersons, please honor our speaker.
बीच में आ जाइए, बीच में आ जाइए। ओके सर, वेट, एक और। मैडम आप उधर क्यों चली गई? या
Dr. Sandeep Gupta, UP, UMS, SAFI, please honor the chairpersons with a memento. May I invite Professor Yashwant Kumar Rao, HOD, Pediatric Department, GSVM, to deliver a talk on a randomized controlled trial on comparison of clinical outcomes in children with uncomplicated SAM managed with and without antibiotics.
Good morning, everyone. It's giving me immense pleasure to introduce our head of department, Dr. Yashwant Kumar Rao. I am from this department. I am professor here. Yashwant Kumar Rao doesn't need any introduction. He is a very good-hearted person, despite of a good acquisition, lots of research work. I request all the respected seniors which are here present to kindly come and see our Department of Pediatrics, which has been taken to a great height under the headship of our Dr. Yashwant Kumar Rao. We are running the largest PICU in the UP state, 33 bedded, larger than the KGMU. We are running one of the largest NICU, having a least mortality rate in the state. So I highly appreciate if you all seniors please come and see our department, what height we have been taken this department in the last few years. Thank you. I request sir for his kind follow.
थैंक यू डॉक्टर शैलेंद्र, हांडा सर, सूती मैम। Respected seniors, for me it's an opportunity to be in front of you as a speaker. I am not a speaker. आपके द्वारा ही सिखाया हूँ, किसी ने मार के सिखाया, किसी ने प्यार से सिखाया। मैं पूरे पैरा को तहे दिल से धन्यवाद देता हूँ और मैं सबके सामने 3 नंबरी और 7 नंबरी लगाना चाहता हूँ। सर वो आप लोग लगवा देंगे तो लगा दूंगा। सर पर्स लेके नहीं आया हूँ सर, सही में पर्स लेके नहीं आया हूँ हांडा सर, 13 नंबरी लगाऊंगा, बोहनी हो जाएगी। Sir, it's not a talk. Initially, I joined the department in year 2006. So before that, research work was almost zero in the GSVM Medical College, Kanpur. So I did my MD from KGMU, Lucknow. So we started doing a small project, ICMR funded project. Now we are getting very big project from the ICMR. WHO, we are doing the project from the WHO on PSBI, possible serious bacterial infection, and this is the part of one my project running in the Department of Pediatrics, funded by the ICMR, 50 lakh project, and we are running this project since 2 years. So I am sharing the data which we get from our project. Before starting the title, I would like to say that in our country, severe acute malnutrition, basically babies who are very thin, lean, thin and stunted are quite high. And in spite of all the therapies, all the treatment provided by the government, data are not reducing. We are just managing the data, not doing anything. So we got the project, and WHO guideline is severe acute malnutrition should be managed either at the community level if there is no complication, but if there is complication, they should be admitted and they should be managed. The babies who are at the community level cannot be admitted, they are okay. Guidelines are use antibiotic in each and every baby. We put the project in ICMR why to give antibiotic unnecessarily if there is no need of any antibiotic. The topic is randomized control. We did the randomized control trial in the community basis to know the outcome if we don't give the antibiotic to uncomplicated severe acute malnutrition child. This is the project sanctioned by the ICMR. Few important data we should be data are very mind blowing type. In India, 33 lakh children are malnourished, out of which 50% of severe acute malnutrition and 50% are moderate acute malnutrition. We are worse than Pakistan, we are worse than Pakistan. And to know the nutritional status in any country, very important parameter is global hunger index. And there are the 4 parameters: undernourishment, child stunting, child wasting and under 5 mortality. And this survey, global hunger index survey, was done in 150 country, and our country India is 116th. मतलब 150 कंट्री में हम 116वें नंबर पे हैं, एंड हम कह रहे हैं कि हम बहुत आगे बढ़ रहे हैं. वी आर प्लेइंग जस्ट विद द डेटा. Second thing, in year 2021 we were at 101. In year 2022 we are at 107. Even Pakistan is better than us. The burden of the severe acute malnutrition, according to the NFHS data, 1/3 of children are under 5 are stunted. 1/3 is stunted in our country, and 1/3 is underweight, and about 20% are wasted. So we conducted the study, community-based management of severe acute malnutrition. Children's age should be between 6 months to 59 months, means ki up to 5 years. So in the community we have to do the appetite test. If appetite test is the mixture of the diet, if child start taking that diet, it means ki appetite test is pass. Means ki that child will be managed at the community by the government, and they should have no sign and symptom suggestive of any complication, has a reliable caretaker who can provide the treatment, who can give the nutrition, and is able to return on feeding center during follow-up. Key component were provision of the therapeutic diet, regular follow-up at home in the decentralized healthcare center. As per WHO guideline, this is very important because our department is challenging the WHO guideline, and this guideline is followed by Government of India. So we are challenging that guideline by this study. As per WHO guideline, antibiotic amoxicillin must be given to every patient of the SAM, whether he is eating or not eating. We have to give on outpatient basis for 7 days. Sir, 33 lakh children are there, they are going to receive antibiotic without any cause. Why? Because WHO is saying, because we don't have our own data in our country, we are just following the guideline, cut paste guideline, and we make it deliver to the community level. No. So we have did this study. Innovative use of the antibiotic, because this amoxicillin is used for an pneumonia, possible serious bacterial infection. How much innovative use of antibiotic is there in our country? With reference to the concept of antibiotic stewardship, we conducted a pilot study in the community. We have given chosen 10 patients and we don't give the antibiotic. All the 10 patients were become normal without any adverse effect. This came an idea ki why to give antibiotic. So our objective was to assess the clinical outcome of management of uncomplicated severe acute malnutrition at community level with antibiotic and without antibiotic. This is the material and method. I am not going to the detail. Study design. Detail of the SAM children were age group between 6 months to 5 years, weight for height less than 3 standard deviation, bilateral pedal edema, and mid upper arm circumference less than 11.5. So we have chosen the SAM child in the community. We divided into 2 group, control and intervention group. In each group there are the 50 children. In control group we are following the guideline of WHO, same guideline, we are giving the antibiotic amoxicillin, and in the intervention group we don't give any antibiotic, just follow other guidelines, but antibiotic not given. Now see the outcome. We followed and results are, most of the children included in the study in both antibiotic and without antibiotic were from lower middle, because in any RCT both the groups should be similar. So they were similar in demographic, clinical demographic profile, age group, age wise, sex wise, both were similar in control group, and out of these complications were the same. Diarrhea, admission were same in both the group, both in control and intervention group. These are the outcome, because outcome is in Z score, जो कि अभी भी मेरे समझ में थोड़ी कम आती है, कम्युनिटी मेडिसिन वालों से कॉन्टेक्ट करना पड़ता है. But you can see we have control group and intervention group. Weight for age, weight for height for age, and weight for height were similar in both the group when we started the study. After 2 weeks of the follow-up, we did this, and after 2 weeks, results were weight for age, height for age, and weight for height were similar. You can see the p-value were not significant. Means कि after 2 weeks of the follow-up, there was no difference either in the control group or in the intervention group. Means whether you give antibiotic or you don't give antibiotic, results were similar. So why to give antibiotic? This is the comparison from baseline. You can see baseline Z score were 0.97 and after 2 weeks 0.82. So there was a significant, means ki in control group where we given the antibiotic, p-value were significant, means after 2 weeks there was increase in weight, there was increase in, but no increase in the height, because in 2 weeks height will not increase. In intervention group same result were there, means whether we give antibiotic or we don't give antibiotic, results are similar. So discussion is, in this randomized control trial we found that routine use of amoxicillin was not superior to the placebo for nutritional recovery in children with uncomplicated severe acute malnutrition. This finding challenges both WHO and Government of India guideline that support continued use of broad spectrum antibiotic. So conclusion is, in this study, optimize the use of antibiotic in uncomplicated SAM at community level. A randomized control trial was conducted and all the protocols laid by the Governing Institute for Management of SAM patients were followed. It was concluded that antibiotic is not needed at all until unless child is having some sort. Thank you. Any comment? And sir, we have sent this paper to IJP, and it is almost going to be published. One more query was there. They are going to publish it. So hopefully we will write it to the government of India to change our guidelines.
Your sample size should have been little bigger.
Sir, actually, it's a 3-year study. It's a 3-year study. So still we have completed only 1.5 year. So sample size is 400 in both group.
Yeah, then it will be more challenging.
Yes, sir. Yes, sir.
WHO.
We are doing that.
WHO is doing marketing.
Yes, sir.
This we have understand in the COVID era.
Yes.
Thank you, Dr.
Hello.
Thank you, sir.
Any questions from the chairperson?
Hello.
Comment, sir.
Thank you so much, Dr. Yashwant, for
Thank you, sir.
delivering such a beautiful box and also informative that is new trends is going now. We have to use or minimize the use of antibiotics in these newborns or pediatric age groups because these antibodies not only provide harm but also prolongs the duration of hospital stay also. Sometimes
Yes, sir.
these antibiotics produces the lethal complications which is very difficult to treat.
Yes.
So it's going very nice that we are using these antibiotics in very minimal no antibiotic therapies. We have to use antibiotics when we have concrete supports of pathology, clinical investigations, and also whether these antibiotics are suitable for baby or not. Thank you so much.
Thank you, sir.
Chairperson, please felicitate our speaker. I request Dr. Rahat Hadi, RML Medical College, Lucknow, to please honor our chairpersons. Our next talk is going to be delivered by Dr. Rakesh Tripathi. Our next talk is going to be delivered by Dr. Rakesh Tripathi, Professor Pediatric Surgery, GSVM Medical College, Kanpur, on congenital malformations in pediatric surgery. As chairpersons, I invite Dr. R.K. Maurya, Professor, Department of Surgery, GSVM Medical College, and Superintendent in Chief of Lala Lajpat Rai and Associated Hospitals, Kanpur. He has been in charge of Office of Medical Superintendent and Medical Records Section, GSVM Medical College. Sir specializes in laparoscopy and endourology. And I request Dr. Shrikant Tiwari, Senior General and Laparoscopic Surgeon from Urai.
Good morning, seniors, teachers, and my colleagues. Today my topic of discussion is congenital malformation in pediatric surgery. Though it's a very vast topic, but I have to concise in very small time. This is the list of common congenital anomalies. First of all, started with the esophageal atresia. This is the most important challenging anomaly. It's supposed to be one of the epitome of pediatric surgery. The first survival reported in 1940, but nowadays we are say that our nearly survival rate is more than 90%. Most common variety is upper pouch is blind and lower pouch is opening in the trachea is supposed to be type 3, almost is occupy about more than 90% cases of esophageal atresia. Other more than 5-6 other anomalies are also reported. Most of the patients present with the antenatal ultrasound in polyhydramnios. After birth, the child present with respiratory distress as features of aspiration pneumonitis, and we are not able to pass NG tube more than 10 to 11 centimeter from the lower lip. With X-ray by investigation, we can get diagnosis of the, just pass the NG tube and take the X-ray of chest and abdomen. If NG tube is not going beyond more than 10 centimeter, is suggestive of esophageal atresia. If abdominal X-ray showing gas, then it is suggestive of associated fistula, and there is no gas in abdomen, then it is suggestive of complete esophageal atresia. This is the X-ray showing coil of endoTube in the upper abdomen. This gasless abdomen, suppose a pure esophageal atresia, and abdomen full with the gas, suggestive of tracheoesophageal fistula. The early management, keep the patient in prone position to minimize the aspiration of the gastric content. Repeated suction. Start with the IV antibiotic, and definitive management by either right thoracotomy with repair of esophagus and ligation of fistula. In cases of pure atresia, we go for the esophagostomy and gastrostomy. Congenital diaphragmatic hernia. Just I am giving a brief introduction. I am not going in the detail of proper adequate management. The congenital diaphragmatic hernia, one of the most challenging surgical anomaly, but it's not a surgical emergency, it's supposed to be medical emergency. Its incidence rate is nearly about 3,000 to 4,000 live births, one case in 3 to 4,000 live births with slightly female predominance. Most of the time is present on the left side, about 85 to 90%, occasionally bilateral and right side. On the position in the diaphragm, it can be classified posterolateral, a most common Bogdalex hernia, which occupies almost 90% of the cases. Sometimes it can present as a hiatus hernia or pasaesophageal hernia or retroesternal Morgagni's hernia. The clinical feature, child present with respiratory distress and cyanosis. It can be tachypnea, tachycardia, cyanosis. Trachea and apex beat may be shifted. Diminished breath sound. Bowel sound can be heard in the chest. Abdominal picture is expired abdomen due to absence of bowel content. Chest X-ray will show the intestine coil inside the chest cavity. Blood gas analysis suggestive of respiratory or metabolic acidosis. Antenatal ultrasound suggestive of polyhydramnios, chest mass, mediastinal shift or gastric bowel. Early diagnosis is suggestive of poor prognosis. Again, any congenital anomalies, earlier the diagnosis, most of the time is poor prognosis. Most important thing to remember, don't do bag and mask ventilation. Always try to ventilate the patient by either intubation or nasal cannula oxygen. Keep the child warm. Evaluate the associated anomalies like 2D echo, ultrasound abdomen to associated other anomalies. Surgery is not an emergency. It's a medical emergency. Once the patient is stabilized, his ABG is improved, need minimal ventilatory setting, then the patient to be operated. This is the X-ray showing bowel loops inside the chest cavity. Duodenal atresia. Come to the start with the GI tract. Most common, one of the atresia, intestinal atresia. Incidence rate is almost 1 in 2,500. Mostly patients are the premature because they are associated with polyhydramnios, early rupture of membrane, because most of the amniotic fluid absorb in the proximal jejunum. Child present with recurrent bilious vomiting on day 1-2 of the life. Child come to us dehydrated, scaphoid abdomen, with visual peristalsis from left to right. Plain X-ray showing classical double bubble sign. Serum electrolyte may show hypochloremic alkalosis, hypokalemia and hyponatremia. We have to do the echocardiography, renal ultrasound to evaluate or to rule out associated other congenital anomalies. Fetal ultrasonography may show again the double bubble shadow and polyhydramnios. This is the X-ray showing double bubble sign. Management. You have to just give the supportive treatment, nil-orally, nasogastric aspiration, IV fluid, and then once the patient is stabilized, plan for the definitive surgery, either duodeno-duodenostomy. Intestinal malrotation and mid-gut volvulus. This is again a cause of duodenal obstruction. It's mostly occurs in 1 in 5,000 live births. About 40 to 60% of the patient present in the early neonatal period. It's occur because the normal process of rotation is arrested. The base of mesentery get narrow. The cecum lifted upward and the DJ junction come on the right side, which create the narrow base, which causing recurrent volvulus formation. Just this see the volvulus of the malrotation. Clinically present with the bilious emesis, irritability, abdomen is soft and scaphoid abdomen, but is required X-ray may show dilated duodenum with some air fluid level, and lower abdomen is gasless, a scanty amount of the gas. USG may show the whirlpool sign. This cases showing some kind of ischemia occurs in the cases of midgut volvulus. Patient require early management. Symptomatic child should be managed immediately by once the correct the dehydration and electrolyte and go for the exploratory laparotomy with the correction of malrotation. Sometimes we have to place the large gut on the left side and a small gut on the right side. So we prefer to do appendicectomy at the time of surgery. Jejunal atresia, its incidence is about 1 in 3,000 live births. There is no significant sex difference. Etiology is not exactly known, supposed to be one kind of ischemic event, occurs in the late intrauterine life. Child presented with the bilious emesis, abdominal distension, jaundice, and failure to pass meconium or scanty amount of the meconium. X-rays more show air fluid levels and contrast enemas showing microcolon. This is the case of jejunal atresia, the grossly dilated proximal segment and thin out narrow distal segment due to complete block. Management, we have to again put the patient like any intestinal obstruction management, nil-orally nasogastric aspiration, correct the dehydration and electrolyte management, and go for the exploratory laparotomy with end to back anastomosis. Omphalocele is incidence rate in about 1 in 4,000 live birth, slightly male predominance, and this is the second most common abdominal wall defect. It's not the most common abdominal wall defect. Antenatal ultrasound can diagnose the omphalocele in almost 75% of the cases. Early detection can be done even at the 18th week of the life. This is the picture of huge omphalocele. One is important thing, it can be delivered vaginally. It is not mandatory to do the cesarean section for the all kind of omphalocele until unless it is not size more than 5 centimeter. If there is respiratory difficulty, you can put the patient on mechanical ventilation. Otherwise, put the rise tube, correct the dehydration. These patients may require almost 30 to 40% more IV fluid than usual requirement. Surgical management to be done after resuscitation. A small defect can be closed primarily, but for larger defect, you may need some kind of silo placement or mesh replacement or delayed repair. This is the picture of silo placement, just covering the whole intestine in the polythene, sterile polythene cover to avoid dehydration. Gastroschisis, this is a defect on the right side of the abdominal wall, and this is the most common abdominal wall defect with a slightly male predominance. Antenatal diagnosis can be done by the ultrasound, with sensitivity supposed to be about 83%. This is the picture showing grossly gastroschisis, showing all bowel outside the abdomen. This surgery to be done immediately. Once the child delivered, can be vaginal. If the vaginal delivery can be again possible. Patient just keep the bowel in the warm, saline, moist and sterile dressing. After resuscitation, immediately shift to the operation room and do early surgery. Earlier the surgery, better the result. Once there is some bowel edema developed, it is difficult to accommodate the bowel inside the abdominal cavity. Again, the Hirschsprung disease. This is a congenital megacolon disorder characterized by absence of ganglioles in circular and longitudinal muscle layer, which incidence in 1 in 5,000 live birth. It can be short segment Hirschsprung disease, long segment Hirschsprung disease, or ultra short segment disease. This is the picture showing transition dilated proximal zone. This is a transition zone, and this is the narrow aganglionic segment. Child present with abdominal distension, failure to pass meconium, and PR examination, the stool with gush of the air suggestive of enterocolitis. Late cases may present with the bilious vomiting and failure to thrive. By investigation, plain X-ray abdomen is showing dilated proximal colon with absence of gas shadow in the pelvic colon. Barium enema shows the transition zone in between the dilated proximal colon and a small caliber distal colon. Rectal diameter is same or smaller than the sigmoid colon, suggests of Hirschsprung disease. This is the barium enema picture showing dilated proximal segment and contracted distal segment. This is the aganglionic. Treatment: keep the child nilorally, IV fluid, nasogastric decompression. Rectal irrigation is only severe enterocolitis. We don't do barium enema within 48 hours of rectal wash, otherwise you can miss the transition zone. First do the colostomy and take the biopsy, then definitive repair to be done on the later on. Imperforate anus, incidence is about 1 in 5,000 live birth, most common in females in rectovestibular fistula, in male child rectourethral fistula, slightly male predominance. On clinical examination, if there is perineal staining, there is a perineal fistula. In vestibule, there is a vestibular fistula, and if perurethral meter is suggestive of rectourethral fistula or rectovesical fistula. If a single perineum opening is suggestive of cloaca. No meconium is staining. Plan for the prone cross-table lateral X-ray after 24 hours of birth, and plan for the surgery after investigation to rule out vector anomalies. Treatment is either colostomy followed by definitive repair if needed in the two-stage procedure. This is the X-ray showing low type anomaly. It can be managed by the limited PSHRP anoplasty alone. And this is the high type anorectal malformation, requires colostomy followed by definitive repair, and further the colostomy closure later on. Posterior urethral wall. This is the commonest urinary obstruction anomaly. In urethral obstruction anomaly is present in the early age of the life. Again, the early presentation, poor the prognosis. Incidence rate is 1 in 8,000 live birth. Patient present with the palpable distended bladder without palpable kidney. Even the empty bladder is palpable in posterior urethral wall. You put a infant feeding tube, drain the whole of the bladder, but again bladder remain palpable. May child present with the urosepsis or urinary ascites.
Please honor us speaker with the memento. Sir, please honor our speaker with the memento. I request Dr. Rajiv Bhargav sir to please honor our chairpersons. Rajiv Bhargav sir. Our last talk of the session is on syndromic approach of testing by multiplex PCR or microarray from animals to automation. It's by Dr. Balramji Umar from AIMS Rishikesh. To chair the session, I call upon Dr. Amit Garg, Professor in HOD Microbiology, LLRM Medical College, Meerut. Dr. Amit Garg and Dr. Ekta Jain, Senior Consultant Pathologist from Ghaziabad. I also call Dr. Shashikant Mishra, Senior Consultant Pathologist and Blood Bank in Charge, UHM District Hospital, Kanpur. Chairpersons, please come on the stage. I would request the chairpersons to please introduce our expert speaker.
Dr. Balramji Umar. He's a professor at the Department of Microbiology, All India Institute of Medical Sciences, Rishikesh. He had done his MD Microbiology from King George Medical University in 2005, and he had an experience of more than 15 years of research experience with national and international collaborations, and having more than 72 publications and book chapters in national and international journals, and he's also a general editorial board member and reviewer in more than 14 national and international journals. So we all welcome Dr. Balramji Umar to deliver his lecture.
Thank you. This is working? Yes, sir. I will take the slides. It's nice to be here on this dais from the college, from the institute where I have studied, where I've been nurtured like anything. Thank you all my teachers. Thank you Principal Sir. And today's my topic, what I want to message you, that we have been evaluated like anything. Our diagnostic has from the animals to the automation system. The technique is now from those ducks, dogs, mice. Now we have carried to the mechanical learning, machine learning, the artificial intelligence. So my topic is from animals to automation, a syndromic approach of testing by multiplex PCR microarray system. So this is my institute, AIMS Rishikesh, a spiritual city. So you can see from 1925 to 19, it was the animal inoculation, monkeys on the mice, the embryonated eggs, the diagnostic was developing. In 1950 to 1965, the cell cultures were made, the cell lines were developed, and from later on in 60s to 80s, it was the serological or the immunoassays or the radio immunoassays were developing. And finally, there was a revolution, a large revolution. We turned to the molecular level, the recombinant DNA technologies. And finally, it's the automation. The machine has taken over the diagnostics, but the human brain is the biggest machine, biggest automation that cannot be ruled. So as per the International Union of Pure and Applied Chemistry, automation is defined as the replacement of human manipulative effort and facilities in the performance of a given process by mechanical and instrumental device that are regulated by feedback of information, so that an apparatus is self-monitoring or self-adjusting. खुद डिसाइड कर लो क्या एडजस्ट हो रहा है, क्या कंट्रोल्स हो रहे हैं, खुद टेस्ट कर लो. बट फाइनली there's again I will re-emphasize, the human learning is the best over the machine. मशीन कुछ गलत भी पड़ेगी तो ह्यूमन माइंड उसको सही कर सकता है. So it was a type of automations, different automation are type been developing. It is the modular automation, selected modules like analyzers, different analyzers, and the laboratory automation system, and now there is a concept of total automation of the laboratory, which is a very actually manpower is also basically a limitations in the institutes also, in the laboratories also. So these things are developing. The technical persons are less, and we are doing more and more diagnostics. So we will just jump through the different machines which are being used in present situation. The chemiluminescent immunoassay, you can see the time of diagnostic is very limited, and these are high throughput machines, and they can give thousands of results within hours. So as we all know, that is, these luminescence machines are based on the fundamental of emission of the visible of near visible radiation, which is generated when electron transition from an excited state to the ground state. That gives the luminescence, and that is red automatically. So these machines are highly specific, highly sensitive, and very high through output is there. Another is the automated ELISA systems. These are also very efficient, which we in initial days there were different semi-automated machines in which we read the ELISA readers and all ELISA systems, and we have to put each thing manually. You just put the sample on the tray and you will go through like anything. Now this is the latest technology, the Panther system. In the COVID days, it was used from in the US, UK, and in our institute we have bought this, and it's almost 1,000 tests in a day. More than 1,000 tests in a day it can be done. And it's not only uses for the COVID, it can be used for other viruses also. Other simple systems are like PCR extraction machines, are real-time PCRs, and the different gene sequences. Now, in the time of COVID, we are also seeing the sequencing machines. Now, these sequencers are very versatile. They tell us about the different variants, and that variants, according to that, treatment is also moduled, and the diagnostic is also moduled, and the epidemiology is also moduled, and the prevention is also moduled. Another what I've told you, the total laboratory automations. BD and bioMario people are doing for the microbiology systems. They are doing it right from the culture preparation of the culture media to the streaking of the material, and also automated reading also. Now you have just to visualize each thing, and total automation is there. They're expensive, but it is existing now. So I will come fast towards my topic, actual topic, that is the syndromic multiplex PCR testing approach. So what is syndromic? The syndromic means symptom-driven broad grouping of the probable pathogen into one rapid test that maximizes the chance of getting the right answer in a clinically relevant time frame. अब हम जैसे lot of time we see disease. Now all the clinical symptoms are all alike. So what we have to do, we are not knowing it is infection due to virus, it is infection due to bacteria, it is infection due to fungus. Now this system takes a small chip, and there are a lot of probes in it, and you with a simple single sample in a run of 2 hours you get a diagnostic what it is, and that will help in management. So I will take you to a small case study. Like 5-year male, fever, have no chills and rigor for 2 days. There was a fever spike of 101.3 degree, vomiting and headache. Neck stiffness was positive. CRP was negative, leukocytosis, neutrophilia. CSF cell count was 560 by millimeter cube, and 80% with polymorph, glucose 67, protein 45, MRI normal. अब इसमें देखने पे लग रहा है कि क्या है ये? Now when we do this with a syndromic approach, the answer comes to be encephalitis meningitis panel, that is positive for enterovirus, and with the normal microbiology, we can't diagnose this. And there are a lot of cases which are reported worldwide with these enteroviruses. And I want to say, re-emphasize again that use of antibiotic in such cases, unnecessarily use of antibiotics will be there. So we can save those antibiotics, we can save those cost-effective mechanisms, and as you know, whole world is running short of antibiotics. Number of antibiotics are less. Another case study: 68 years old male admitted in emergency, history of maculovascular rash over the right buttock since 7 days. This was followed by similar rash over left tongue and lumbar region. 1 day before admission, altered behavior and fever, no headache. Now, MRI was done, but nothing significant. CSF was also not significant, urine, blood culture, they were all sterile. So what comes? The diagnosis of herpes zoster. Now you get the diagnosis, right diagnosis, you will give him the acyclovir and it will respond. Now these, some of the chest x-rays, they show different type of alveolar infiltrates. They all look alike. What it is? So you can see these are different panels. You can see the human rhinovirus, human metapneumovirus, EVD68, adenovirus. These are diagnosed with the syndromic management. You don't have to give the antibiotics here. So if the clinical symptoms are all alike and you are not getting not getting any positive thing in the routine diagnostic, you have no option other than to just give a trial of medicine, right? So it is a time consuming process, labor intensive. You have to use lot of diagnostic tools which are time consuming, labor intensive, technically complex, low yield, cost and overheads, limited coverage, and lack sensitivity and specificity. And moreover, there is cost factor also. So we have to do a syndromic approach. So this gives a faster and better results because it is easy, 2 minutes of hands-on time, gives result in 1 hour, comprehensive panels are there, and it is a closed system, so there is no contamination or reduced rate of risk of contaminations, and has got a very high sensitivity and specificity also. So I will take you to a journey, small, how it works. This is a, this is a kit which is being used, has got a sample extraction and preparation system. It has got a first stage multiplex PCR, the second stage PCR, and you see what you have to do in the 2 minutes. The pouch is inserted into the loading block. The hydration solution is injected into the pouch through the blue inlet port. The sample buffer is added to the sample injection vial. The sample is added to the sample injection vial using the transfer pipette. The lid of the sample injection vial is closed and the vial is inverted 3 times to mix the sample. The sample buffer mixture is injected into the pouch and through the red tube it is injected, and the instrument is now ready to set up. This is the instrument, which is a multiplex PCR system, and it takes about 65 minutes run time. The sample moves into the lysis chamber. Cells and pathogens are lysed by beating, releasing nucleic acids, and these nucleic acids are bound to the magnetic beads. An elution buffer removes purified nucleic acid from the magnetic beads. Nucleic acid moves to the first stage PCR chamber, and the reverse transcriptase enzyme converts target RNA to DNA, followed by high order multiplex PCR, and the products of the first stage PCR are diluted to remove any remaining PCR primers. And finally, these are the small chips, small wells on which these amplified DNA binds, and these are finally detected by the assay system, and you have got the melting curves which is automatically read, and with this automatic reading you get to know the type of pathogen which is involved. So these are different panels and these are automatically read, so you get a good result in within 2 hours. So 2 minutes. So these are the different panels. You see, a single panel has got 33 targets. We have 33 targets in a single panel, and all these bacteria, atypical bacteria, viruses, antimicrobial resistance genes are also detected. This is the respiratory panel which has got 21 targets. The meningitis, encephalitis got to have 14 targets. The blood culture identification system has got 43 targets. And there is a new panel also which detects also the bones and joint infection panel. To summarize, the need of the hour is, it is a fast, easy and comprehensive. With over 100 targets, it can detect. And the benefits of this syndromic testing is high impact on the patient management and the cost, a guide to early therapeutic adjustments, a tool for better and safer patient isolation, improved patient management, a significant impact on the healthcare cost. Everything is being worked on today, on the antibiotic stewardship and to reduce the cost. So this is a costly test, but if multiple tests of being done for the same thing, it will be a higher cost. So it is cost effective also. And suppose some viruses is detected and you are giving vancomycin, linezolid and these type of drugs, that also adds to cost and it harms the patient also. So this is a cost effective, very cost effective and very benefit giving syndromic approach. And there are limitations with every automation system which is exist. I told you that nobody can compete with the human brain, and that is from my side. Thank you, and I will like to invite all you to Rishikesh anytime, anywhere, and most welcome, sir. Thank you. Thank you.
Thank you, Dr. Balramji Omar, for giving a crisp talk on such a wide topic. Chairpersons, would you like to add something? Okay. I would request the chairpersons to please honor our speaker. I request Dr. Sameer Tripathi to please felicitate our chairpersons. Dr. Sameer Tripathi. I thank the audience for a patient hearing and making the session successful. Please excuse us for any shortcomings. As we are running out of time, we will proceed with the inauguration. While we are preparing for the dais, a few words. GSVM Medical College Kanpur, known for its academic excellence world over, is named after late Shri Ganesh Shankar Vidyarthi, a great freedom fighter who lost his life at the altar of the communal frenzy in Kanpur in March 1931. This was the first medical college of UP established in independent India, forming a landmark in the annals of medical education in the state of UP. It is one of the 5 medical colleges in India established under the second 5-year plan. Good afternoon to all my teachers, seniors, GEMS delegates, students, staff members, and my beloved Para M1 batchmates, and of course their family members. Today, we all have gathered here to salute our great alma mater, Ganesh Shankar Vidyarthi Memorial Medical College, Kanpur, our parent institution to which we remain indebted eternally. As the Dalai Lama once said, "Give the ones you love wings to fly, roads to come back, and reasons to stay." So here we are once again. The trajectory of our lives might have deviated to places or dreams, near and far, but tracing back our steps, we find ourselves once again at the threshold of the roots where we began our journey together 30 years back, to the destinations we decided to choose. आज हमारे बहुत से पैरा M1 के बैचमेट्स यहाँ उपस्थित हैं, पर बहुत से आज यहाँ किसी कारणवश नहीं आ पाए हैं और कुछ दुर्भाग्यवश हमारे बीच अब नहीं हैं। हमारे सभी दोस्तों के लिए मेरे ये 2 वर्ष समर्पित हैं। तुम खास हो या नहीं, हर सांस में हो मगर, रूबरू हो या नहीं, हर एहसास में हो मगर, मिलो या ना मिलो, हर तलाश में हो मगर, पूरा हो ना हो, हर ख्वाब में हो मगर, दूर हो या करीब, दिल के पास हो मगर. As is customary, I begin our inauguration program by the Saraswati Vandana. Saraswati Vandana, please. The Saraswati Vandana was performed by Ms. Suvigya Tripathi, daughter of Dr. Rakesh and Divya Tripathi, and Ms. Vaibhavi Singh, daughter of Dr. Vishal and Mrs. Praveena Singh. Thank you, Suvigya and Vaibhavi, for a lovely performance.